The broadcast is now starting. All attendees are in listen-only mode.
Hi, everybody, and welcome to Leading Age Maryland Tuesday Tips. This is Kristy Yoskey. I am the Senior Vice President of Clinical Strategies at HealthPro Heritage, and I'm here to talk a little bit about alternative census network development strategies and some data and resources behind that. We are HealthPro Heritage. We are a privately owned therapy in-house consulting and full-service firm. We believe in the power of partnership, which is very strategically our success is our partner's success and vice versa. More so, our partner success is our success. And that's why we're here to talk about some of the hot topics behind census and network that are plaguing a lot of skilled nursing owners and operators around the country today in a COVID-19 pandemic. Gone are the days of meeting in person, having hospital clinical liaisons in the hospital meeting patients. Gone are the days of really high amounts of discharges, 18, 19, 20+% from hospital to home, and the lack of, frankly, community-based services. So today we're in more of a virtual meeting world, building relationships through a camera and a phone and technology, increasing our coordination of care and our complexity of that more chronic conditions in the skilled nursing facilities. And then, of course, we're getting lower overall referrals from hospital to skilled nursing. And some of our partners are beginning and have been using predictive analytics to guide discharges from hospital to the skilled nursing or home setting based on past data and where they see the best opportunities for outcomes over time. So just really quickly before we jump into some of the reasons why I'm here today, obviously, number one, we're in a pandemic. We're in the vaccination stage and getting that distribution out, and owners and operators of skilled nursing are struggling with census. We're down words of 73% occupancy across the nation, which is the lowest occupancy ever since I've been in this business. And as we're looking at the discharges from hospital to skilled nursing in a 12-month period for Medicare fee-for-service, if you look at the final column, second to the last row, 15.2% of the Medicare A fee-for-service discharges from the hospital went to skilled nursing. Home health, the third line from the top, did see a slight decline as well from the previous 12 months, ending quarter one of 2020. They went from 10.9 to quarter two 2020, 8.6. So really any services, trying to isolate, quarantine, reduce exposure, not having enough PPE during this time was really telling. And who knows when this is really going to rebound and how vaccinations will play. But I think it's important to note that we're all fighting for a much smaller amount of potential referrals. Which leads me to my second tip is having a tracking system and trending for referrals from your referral sources, the time it took you to say yes, no, or get more information, and how many you actually accepted. And then also if you've declined any or said no to any referrals, the reasons why. If it's clinical, we've got to boost our clinical capabilities. If it's equipment, we've got to look at doing a better job because every referral, especially more complex, needs more complex resources, more spend, more widely trained staff to take care of those. This is an example where one of our partners that we're working with currently had one particular referral source in 6 months, received 513 total referrals, said yes to 381 for a 74% acceptance rate. Interested and needed more information in 33, said no to 99. We did review those, but it took them an average of 3 hours and 26 minutes to get to a definitive answer or respond. They actually only admitted 124, so their total admit rate or conversion from referral to admission was 24%. This partner is asking me to help them with additional census and referrals from their accountable care organization. They're a wonderful provider, but struggling with the process of actually referring, getting the yes, no, or need more information quickly and getting those patients in their doors. So there's some work to do on the front end before we bring in more referrals to take longer to decide. So some of the process that we have to work through. The second part of the conversation today in this 10-minute talk is really looking at new possibilities for census. With things moving towards predictive analytics and at-home services growing within a pandemic, it's important to understand where you have other avenues. We're used to typical hospital to SNF, maybe even emergency room to SNF to SNF. But we haven't done a lot with downstream partners, so home health, senior livings, just primary care physicians in the market. That's where we're really going to focus today, is looking at the physicians who are truly seeing these patients either through telehealth or in visits, and they may need an institutional stay or a shorter stay or a longer stay, even based on how they're doing in the market today. And also how to leverage the 1135 3-day qualifying hospital stay waiver through the end at least of 2021, unless the Health and Human Services Secretary for the Biden administration opts to end that with a 60-day notice. So my final piece is really the resource of transitional care management in a skilled nursing facility. You can use this and leverage it in senior living as well. If you have a patient who goes from hospital to SNF, SNF to home, coordinating from the SNF level with a physician that's the primary care physician in the market, letting them know prior to discharge so they can essentially initiate this transitional care management 30-day episode billing for the services that they typically already provide. You're essentially connecting with a primary care physician and saying, we want to increase our care coordination, which would increase your billable units. We'll coordinate with you ahead of time so you can take advantage of the 2 business day non-face-to-face communication that needs to happen in order from that institution to the next level in order to initiate the billing of this 30-day episode. And by the way, we have all of the steps in the process, the non-face-to-face 2 days that we can help you coordinate, the care coordination, downstream providers, with downstream providers and caregivers post-discharge from our skilled nursing. And then we'll assist you in scheduling that face-to-face within 7 to 14 days, depending on the complexity of the patient. And then we'll also give you tips and tricks of how to document and support those transitional care management codes. And then the billing happens after the 30-day episode. So it's really great for the patient to leverage this, but it's also really great relationship building with the physician. Knowing what happens from the primary care to the hospital to the SNF, what happens with their patient, when they can follow up, increase their billable units, increase the time that the primary care and the SNF and the downstream providers spend to better coordinate what we call population health or better coordinate care, is a win-win-win for every single person involved. So I know we spend a lot of time talking through this with our partners. Really great program. And again, it's to leverage, number one, the population health and care of the patient from one level to the next and coordinate that care effectively. The other is a census and network strategy to connect with your primary care, say, we'll coordinate with you, we'll help you with this. You can then bill more units and make sure that your patient is getting the services that they need post-discharge of an institutional stay based on the complexity of the patient. So we put in process what we need to in the SNF from a communication standpoint, rehab or social service or both, coordinate that. We work with admissions and marketing from the physician standpoint to get physicians buy-in to this program. And then we create a flow and a work process from hospital to SNF to home with the physician in order to get these services billed. And then essentially the physician wants to refer more patients to you because of the coordination of care and the better care and reduction of hopefully readmissions based on the transitional care management program. So a lot of stuff here to unpack. I only had 10 minutes, but I wanted to at least introduce it to you, and hopefully I'll be back to go in more detail of some of the physician strategies that you have to make sure your SNF has alternative census and network strategies within the continuum as we move towards a lot more home and community-based services and needs of the community at home, who also may need a stay, short stay, long stay in a skilled nursing facility in the future. Thank you all so much for joining Leading Age Maryland and HealthPro Heritage for Tuesday Tips this week, and hope to see you soon. Thank you.